Hi, my name is Natasha, and I am talking about the clinicopathologic correlations of the neurological chapter in our book. And this chapter, or this part of the chapter, really talks about the comatose patient, and it defines coma as the state in which a patient is unable to respond to any stimuli. And there are many causes, and this can be a meningeal infection, increased ICP from any cause, subarachnoid hemorrhage, a focal cerebral lesion, a brainstem lesion that affects the reticular system in the brain, and then metabolic encephalopathy and post-seizure activity. Also, you can have someone that falls into a coma. The book, it was a little confusing at first. The book kind of dives into assessing a comatose patient as if you've never seen the patient or you're not getting a report on them. Almost like in an emergency situation where you're not knowing what's going on with the patient. So they recommend to converse with friends or family members of the patient to gain clues as to why they're in a coma. So you want to get a history, such as, does this patient have hypertension, diabetes, epilepsy, substance abuse, or have they had recent trauma? Were they in an accident? Do they have a head injury? If they do have a head injury, you're going to want to get x-rays of the cervical spine before you proceed with your exam or before you move the patient's neck. So the physical inspection or the physical exam should always start with an inspection. So your look, listening, feeling, smelling, everything that you possibly can to get as much information as you can about this patient. These will all lead you to understand if they have a chronic illness, if they're, what their age is, and it'll give you valuable clues as to why they're in a coma. If you smell like something like a sweet breath, it might lead you to think, oh, diabetes with diabetic ketoacidosis. So your inspection is really going to be the foundation of your physical exam. Stop. During your inspection, you want to look at the posture of the patient. Are they in a decorticate or a decerebrate posture? Decorticate meaning their limbs are coming in towards the core, and then decerebrate meaning the opposite. So their arms are extended, their wrists are flexed outwards. Important to note that in both postures, the feet are going to be plantar flexed. So just looking at the feet alone, you won't be able to tell which posture they're in. And it's important also to note that whatever posture they're in will tell you which part of their brain has been affected. So if they're in decorticate, they are having a cerebral hemispheric dysfunction or a destructive lesion from the pyramidal tract. And then if they're in a decerebrate posture, they're having an issue in their midbrain or their pons lesion. So there's actually some pretty good pictures in the book. We can go take a look at those when you get a chance. They're pretty good. I think the book also touches on the head should be evaluated for any areas of depression or injury. So you want to look for skull fractures or any type of CSF leakage. Pay attention to that because that will give you a clue as to why this patient's in a coma. We should be looking at respiratory pattern, such as, I can never pronounce this word, Cheyne-Stokes, I think is how it's said. So rhythmic changes in breathing with marked periods of apneic breathing, so no breathing at all. This type of breathing is associated with a brainstem compression or bilateral cerebral dysfunction, so the whole on both sides. Continuing on with the neurological examination is going to be largely based on the pupils, so their size and the reflex to light is what you're looking for. So they're going to be dilated after an overdose from hallucinogenic agents or stimulants to the central nervous system. So something like cocaine or some other type of stimulant, the pupils are going to be dilated. A unilaterally fixed and dilated pupil is indicative of pressure on one side of the ocular motor nerve. So this is only on one side, so pressure that's only occurring on one oculomotor nerve, not both. And this can also be indicative of an uncal herniation, so when the brain is actually descending from the bottom of the skull and pressing on those nerves. Additionally, presence of a normally reactive pupil with an absence of a corneal reflex to light, or absence of extraocular movement can be indicative of a metabolic abnormality, which could be the reason for the coma. So something like a diabetic ketoacidosis. If their pupils are reactive and they're moving appropriately, but they're still in a coma, it could be a metabolic issue, not so much traumatic injury. So moving on, if there's no evidence of a fracture, you want to check the oculocephalic reflexes via either the doll eyes or in combination with the doll eyes, the caloric stimulation. So you would tilt the head rapidly one way to see if the eyes move towards that side or towards the other side, and then with the caloric stimulation you would put ice water in the ear and or warm water, and this can be represented by the mnemonic cows for cold opposite, warm same. So that's just a way to test level of injury within the brain if someone's in a coma. Then the book goes to talk about headaches and the difference between migraines, cluster headaches, tension, hypertensive headaches, increased ICP, meningitis, or temporal arteritis. It has a nice little chart in there that you can go over. There's a lot of detail. Continuing on, it talks about extrapyramidal type of assessment for motor activity. So these are parts of the motor system that are not directly involved with the pyramidal tracts along the spinal cord. It's composed of the basal ganglia, the nuclei of the midbrain, and the reticular formation, as well as the cerebellum. So then the book talks about neurological conditions such as MS, ALS, Parkinson's, myasthenia gravis, and Huntington's disease. It talks about the ages, and then some of the signs and symptoms. There's a really nice chart in there, but for time's sake I won't go through all of them. It goes on to talk about paraplegia versus quadriplegia, so upper motor neuron versus upper and lower motor neuron involvement, and then spasticity versus flaccidity, and the difference in types of lesions on the spinal cord, and which leads to either spastic or flaccid type of reactions. Talks about motor function according to cord segments. So your C-spine is going to be your shoulders, arms, hands, and fingers, and then your thoracic spine will also be part of the hand, your fingers, your hips, or excuse me, your hands and fingers is mostly your thoracic, and then moving on to your lumbar will be your hips, feet, and toes, and then sacral will also be hips, feet, and toes. So it's an important distinction to know at which level of the spinal cord correlates to which movements of the body. And lastly, the book talks about vocabulary, STEM words such as myelo, meaning spinal cord, paresis, meaning weakness. There's a couple more examples. I would recommend going over those. And that is it. Thank you.